this week on the BackTable podcast.
We initially had nurse practitioners doing a lot of the pre-op counseling, and we teach everyone self-cath and going over the patient instructions and the ARISH protocols. And our nurses were like, we would like to do that. I mean, we think that we can spend that time educating patients. And so they just became interested that they wanted to be part of that healthcare team. And I think that we also spend a lot of time on terminology and semantics that, you know, the National Academy of Medicine defines what team-based healthcare is. And so we make sure everyone understands that, like, we are functioning as a team and we're providing team-based care, which actually provides value to our patients. And it also, like, provides value to every member of the team because nurses aren't just doing trivial things. They're actually working with patients, they're educating patients, they're actually using their professional licenses to make decisions.
Hello, everyone, and welcome to the BackTable OBGYN podcast, your source for all things obstetrics and gynecology. You can find all previous episodes of our podcast on Spotify, Apple Podcasts, and on BackTable.com.
So welcome to another episode of BackTable OBGYN. This is Amy Park, and I'm here with my co-host, Mark Hoffman. Hey, Mark, how are you doing?
Good, Amy. How are you?
Good, thanks. And I am so pleased to welcome our special guests today, Doctors Kenton and Maggie Mueller. I'm going to hand it over to them so they can tell us a little bit about themselves, and then we'll just segue right into the show. So, Kim, why don't you go first?
Well, we're so excited to be here and talk to you guys a little bit about some of the work we've done around patient recovery. I am a urogynecologist. I work at the University of Chicago. I have spent a lot of time doing not only surgical trials, but actually trying to improve how women can recover from surgery and improve their quality of life.
I'm Maggie Mueller, also another urogynecologist. Very happy and excited to be on this podcast with such great colleagues. I would say that I became interested in postoperative recovery way back when, probably when I was a fellow. I'm inquisitive by nature and probably questioned, why are we doing this? And it seems like a lot of other people. And in my residency training, I learned how to do that. And that spawned an idea for a randomized controlled trial that was completed in fellowship and kind of has continued to, produce other questions that we are actively looking at studying. So thank you.
So can you give us a background on why postoperative restrictions even exist after gynecologic surgery? Like, why do people even tell patients or counsel their patients like that?
I'm happy to take a stab at this. So I think that it all comes out of surgeons trying to do the best that we can and trying to protect our patients in the best way that we can. And sometimes that doesn't involve really evidence-based decision-making and just, we rely on what we think might be right, the way that we've always learned, the way that it's been handed down from generation to generation. And so then we start to rely on these anecdotal instructions. And it does make some sense that you should limit your activity because something bad could happen. But I think that what really started to transform this thinking in postoperative recovery is probably some of our colleagues in orthopedic surgery that started to really question whether it was good to be resting and not loading joints and ligaments, etc. And now they've really kind of revolutionized the way that people recover from orthopedic surgery. So again, I think it really came from a good place, but might have lacked some of the information or evidence that we hope to be able to provide patients.
And then tell us about your process. You said in fellowship, you were like, I'm very curious about this. Were you just like, did you have a moment where you just thought, well, this is kind of like, why are we even doing this?
Yeah, I mean, it was probably like pretty early on when I read the instructions and realized that, we didn't really, in my fellowship program run by Dr. Kenton, we didn't really provide any restrictions on activity. And that's certainly something different than the practice that I had learned in residency, where we were pretty strict about restricting any activity, heavy lifting, anything heavier than a milk gallon. Like everybody is familiar with all of these recommendations that we've provided for so long. So I probably came in day one, and I mean, I'm sure I was annoying to somebody asking all these questions saying, why are we doing this? And then that kind of spawned that line of investigation.
Just to kind of piggyback on that, when this first kind of arose in my mind was when I was a fellow. We had those, I call them antiquated, don't lift anything heavier than a gallon of milk or 5 pounds for 3 months, no high impact activities. And I spent 3 months of residency with Tony Smith in England. And he was like letting patients go back to full activities in like less than 6 weeks. And I was aghast. And I was like, oh my gosh, how can you do that? And he said, in his very nice British accent, well, is there any data for what you do? And I said, I don't know. And we started looking at it. And I think that's how we evolved over time. So starting to look at the literature and realizing that what we were telling people to do had no evidence based. And then when we started talking to patients, most of them were doing it anyway. So they would tell you that, oh, yeah, like, sure, I'm not going to do any high impact activities for 3 months. But when you actually kind of drill down and talk to them about it later, they're like, well, I actually did do these activities, which made us kind of back off on activity and lifting restrictions. By the time, Maggie got there, we weren't really doing that anymore.
So you just like the idea of like delving into it further and then really drilling down and seeing what the data was, it sounds like. I will say about the postoperative restrictions, though, I'm a mole on the Facebook group, the APOPS Facebook group, and literally 95% of the Facebook group dialogue is about perioperative restrictions. It's fascinating. All you have to do, pro tip, is answer 3 questions. And then, I want to jump in there, but I don't. But anyway, I think patients like always ask prior to surgery, what are my restrictions going to be? When can I go back to work? Et cetera, et cetera. So I think there's a lot of anxiety about this. And then obviously money and salary implications, et cetera. But I do want to just pivot back to what your trial actually was and what did it show? Like how did you define postoperative activity? And then what did you find?
Yeah, well, I forgot that you were a mole on the APOPS.
Can you explain to non-urogynecologists what APOPS is?
I don't even know.
I think Amy should explain.
It's like this association of pelvic organ prolapse, it's a patient group for prolapse and incontinence, and it's kind of like Nancy's Nook.
Oh, that was my question. Was it like Nancy's Nook?
Or
it's like
sisters, kind of?
Sisters?
Hister Sisters is not a Facebook group. That's like a full-on website, but APOPS is just, one of the Facebook groups. I mean, there's a Facebook group for everything. I'm on a lot of them. I need to mute some of them, quite frankly. But I digress. I do just like to know what kind of is going on in the patient realm, like what is driving it. And this is totally something that takes up a lot of their bandwidth.
Well, it's so interesting. I love that you are keeping tabs on that for us, because that's another kind of line of our interest is how do patients perceive recovery? So what do they think is involved in recovery? Is it getting back to work? Is it going to the grocery store? Is it having pain? Like this is kind of an area that's interesting, overlooked in surgery. And I think that is definitely something, I mean, it's certainly one of our interests to figure out, what do patients even consider to be part of recovery? And then I think that will probably inform a lot of our future instruction, study, et cetera.
Yeah, tell us about what your findings showed.
Yeah, so the initial trial was a multi-center randomized controlled trial that looked at what we referred to as restricted activity recommendations versus liberal activity recommendations. So liberal activity recommendations was really just you can resume whatever activity you like at your own discretion. There were some precautions for things that we're not considering to be postoperative activity recommendations like vaginal intercourse, et cetera. So they still had the same guidelines that many, gynecologic surgeons use, which is nothing in the vagina for 6 weeks. In the restricted group, we said, the common things, so no heavy lifting, no high impact aerobic activity, etc., for 12 weeks. So they were supposed to adhere to those guidelines as kind of our standard guidelines versus the intervention group was the liberal activity recommendation group. And what we found is that the study was actually powered to detect differences in satisfaction. And we found that both groups were equally satisfied, very high satisfaction rates. I believe there were upper 90% of each group was highly satisfied with their surgery. But we did see that there were functional outcomes that were different in the two groups. And interestingly, the functional outcomes like prolapse index scores and functional incontinence index scores were actually improved in the liberal activity recommendations group. So that definitely was something interesting. Maybe like the hypothesis was that people start to do more activity, they get back to their normal, they start feeling better, et cetera, and they're experiencing these improved symptoms. We did follow it up. Certainly, like the major criticism is, well, this is a 3-month outcome. What do you think is going to happen with prolapse later on down the road? So we did follow that up with a secondary analysis of 1-year data. And again, found no differences to suggest that there were any changes or differences between the two groups with respect to prolapse outcomes. So I think that certainly helped to satisfy some folks in terms of, the fear that if you start to exercise or have more activity sooner, you might ruin your prolapse repair.
I was just going to say, like, you brought up that analogy of orthopedic surgery, which is so relevant, I think. I mean, people have swung the pendulum from early ad lib activity to immobilization and now back to early recovery. And I really see our kinds of surgery, all benign gynecologic surgery, as quality of life issues and enabling patients to get back to their regular activities. And I find it so ironic. One of my patients was really upset and said, I don't want to have surgery because I was told I couldn't do any crunches anymore. And I'm like, girl, this surgery is to allow you to do crunches, to allow you to do your triathlon, marathon, try, whatever. It's like, that is why we're doing this surgery, so you can have some healthy living and achieve your goals, just like a knee, just like I don't know, any kind of surgery, orthopedic surgery. So I find it interesting that people are trying to restrict our patients by saying you can't ever weight lift again or whatever. And really the deconditioning, it can be profound, especially for our older patients. And now we know healthy aging is predicated on maintaining muscle mass and grip strength and all of those things. And I just think long term, I can fix your recurrent prolapse if that were to occur, but it's harder to recover from a hip fracture or like a back injury, right? So I think we have to keep the whole picture in mind. I'm wondering if some of it had to do with like hernia data, like our open incisions, like not like our minimally invasive laparoscopic and vaginal approaches, or...
Was there even any data on that though? I think about our training where it was just like in med school, you couldn't leave the hospital after a big open GYN oncology surgery unless you passed gas. And I think we had a little bit of that in residency too. Maggie and I were both residents at the University of Chicago, and patients were like ringing their nursing buttons as soon as they passed gas, just to let everybody know so they could have something to eat. And now it's like, all right, just everybody eat, right? I think it was all of those things. And I don't know that the data supported any of that stuff before it happened. What about open cases? Is there any data to support restriction in those patients either? Or is it all just, we just didn't know?
Yeah, that's really interesting. So I think that, yes. So I think that the hot areas of, these activity restrictions certainly originate in abdominal procedures for hernia repairs, given that, if you're thinking about this increase in abdominal pressure that could happen with, exercise or frankly, what's been shown to be just everyday activity. The worry is that you're loading this, fascia that has, a defect in it without, the appropriate tensile strength. But even that is starting to be, overridden. And we're not alone in the fact that we're kind of all over the place with respect to postoperative instructions for gynecologic surgery, the general surgeons for hernia surgery, they're all over the mark too. So I think that it's definitely, there was some data, but people are starting to question it in a more patient-friendly manner.
Are the recommendations changing for general surgery, for hernia surgeries as well, or is it just that we're starting to look at that as well?
From what I'm familiar with, it looks like they're at least starting to collect the information to see, how, if people are providing more liberal instructions. And that's kind of something that we had seen really early on too. Some of these survey studies that just look at, what are people doing? And then there are some systematic reviews in the general surgery literature with respect to hernia repairs and larger open abdominal procedures, where they haven't really been able to show an effect with respect to the amount of activity restriction and the hernia recurrence.
I also think it's important to remember that the data that we all were taught in medical school, which was, a wound gains like 80% of its strength, tensile strength by like 3 months, and it takes a year to get the rest of it. Those are based on animal models. Like, those aren't human data. So we took animal model data and we just applied it to how we were counseling our patients for decades, and I'm not sure that that's probably was the best way to make those generalizations.
And it sounds like we didn't have anything better.
Yeah, anecdotal medicine at its best. I regrettably still practice a lot of it where there's no data.
I think it's super interesting too, like this ancillary data on the sensors and what really elicits more pressure on your pelvic floor is like the pulmonary stuff, like the coughing and the straining with this constipation, or rather than lifting or bending over or vacuuming. And so those are like proxy data. And then the fact that these functional outcomes are actually improved in the liberal group, I think is really reassuring. Do you think that this is something that is being widely adopted across the U.S., and have we just been very conservative in the U.S. compared to other countries? Because Kim, you alluded to the fact that when you went to England, they were doing ad lib.
And I think that's the great question of the hour. How do you do implementation science? The Duke group did a similar study and had similar results. And so the fact that this is even still a discussion, I think now isn't about the science. It's about how do we get people to accept when we have new data and implement it into their clinical practices, and I think that we're still trying to figure that out in so many things, right?
Yeah, I agree about the implementation side and where are the gaps. And I think there's just general lack of knowledge probably about this because people were pretty engaged at your former fellow, our current partner, Dee Doss's grand rounds about this topic. I think people genuinely didn't really know. And so I think it's important to get the word out. And like I said, patients have a lot of anxiety surrounding this. And then the other data that I think is really fascinating that's coming out at the meetings is when do patients feel like they're fully recovered? And you see a wide range. Like they're like raring to go at like 2 weeks or 4 weeks or 6 weeks. It seems to be 2-week intervals. And it's most of the recovery, if I remember correctly, from what was presented, I think was between 4 and 6 weeks. Do you guys know the data on this?
Yeah, we'll have some more very soon. This sets up looking at how to measure recovery. Maggie's leading a protocol a multi-center protocol right now, looking at just that.
Oh, I thought we were going to have some like breaking news that we were going to release.
Data's not ready for prime time sharing yet.
Stay tuned.
Just a little bit of a teaser.
Yeah, no, that's great.
Amy, and some of like these, we're in some multi-center research groups where we talk about recovery. And I don't think it's just that people don't know. We have a lot of conversations where people are like, well, I've never done that. I can't tell my patients to go back to their activities. And so I really do believe it's like, how do you get us as surgeons to accept the data that's out there?
What was interesting with the cuff checks, right? I think COVID was one of those things that like people were doing some studies and it was like, don't probably need to do them. And our sort of anxiety or our just traditional practice or habits, well, I have to look to make sure it's okay, even though no cuff has ever spontaneously ruptured in front of my eyes. And if they had a cuff issue, they were symptomatic. And so during COVID, it was like, well, just call me if there's a problem because I can't see you. And they all did fine. So it was interesting how it allowed us to sort of push. Now I haven't done a cuff check. I mean, if a patient wants one, we'll do it. But
I won't even do it if they want one. No, really.
I refuse to look in your vagina. That's
only at a certain interval.
Well, no, I mean, 6 weeks out, if they're like, they'll feel more comfortable. I said, there's no benefit. There's absolutely nothing I can do here. But like, would you mind looking? It's like, I mean,
you're nice.
I need those patient satisfaction scores to stay high.
He's an administrator now.
We're keeping our new patient access high. He's an administrator. Every post-op that you see at 6 weeks for no reason is decreasing your patient access.
So you're not doing any post-op visits at all?
We are. We just don't. This is another question that I had when I came into residency or fellowship. There were 1 million people coming for post-op checks all the time. Yeah, the clinics were overrun. We were seeing them all the time, and we couldn't see new patients. So we actually looked at that to see what are the most important post-op visits. And it turned out that looking at outcomes, the 2-week post-op visit is where you can catch those bad outcomes, like some ileus or something like that. So we kept that. And then the 13-week one, you're more likely to find those suture erosions or mesh erosions. So we kept that, and we cut the 6-week one out.
You were doing 3 post-op visits.
So many post-op visits.
Yeah, we were doing 2. I'm not doing urogyn. So just for like a TLH, we were doing 4 and 8. And it was just all of our clinics were post-op clinics. And so we just said, let's just split the difference and do 6. We can't get these patients back. And I haven't noticed a difference.
We've gotten rid of the 2-week based on the randomized controlled trial in the urogyn population out of New Mexico, which randomized patients to in-person visits at 2 weeks and 3 months, or nursing phone calls at both of those visits. And they used HCAHPS data satisfaction. They looked at readmissions. They looked at presentations to the ED or their primary care doctor, and basically found that there was no, it wasn't inferior. I think it was an inferiority trial, but don't quote me. And so our 2-week visits are now nursing phone calls that if they, we have a standardized template that they go through with each patient. If there's a reason to bring them in, we bring them in, but we don't broadly bring in all those patients anymore. So we really are just seeing people in person who are otherwise doing well at 3 months.
What are you doing, Amy?
My previous practice in DC, we did 2 weeks and 6 weeks in person. And I agree with you about the access and the clinic being overrun. And then, you couldn't get in your news or consults. Here, when I came here, they were doing 6 weeks visits, and then now our NPs are seeing them, but their NPs see them either virtually or in person, and we give the patient a choice. I always say we have an open door policy. I tell the NPs and the fellows, anything, just bring them in, no problem, but it hasn't really been an issue.
So they don't see a doctor or surgeon post-op unless they have a concern or a desire.
That's what the University of New Mexico data supports that. We actually started doing that as well, but we couldn't come to consensus amongst the team. Some people wanted the 3 months. We were having our APNs do it too.
So we have a nurse practitioner on our team who would see them, but she, her practice is RVU based and productivity based as well. And so for her to see my post-op, she's not getting RVUs for that. So it's a global billing. So it is depending on your practice, but how do you guys have it set up with your APRNs? Is it just they're salaried and see whatever? Are they productivity based as well? Because technically we're getting paid for that visit, right?
So I think that's one of the things that has helped with the 2-week phone calls. So we've really tried to offload any non-billable things to salaried nurses, for example, so that our PAs can even see some of the 13-week post-op visits, which is technically a billable time frame.
91 days.
Yeah,
always.
It's true.
Yeah, so
outside of the global period.
Yeah.
So
yes. So yeah, you're right, Mark. I think that there's not always this idea that RVUs are important for our physician extenders, but when you go to places that are really looking at collections and things like that, yeah, the PAs and APNs will need to cover their salaries, and the way they do that is with RVUs. So yeah, I think that New Mexico study definitely helped support, like, we can start to transition some of these non-billable things to nurses.
Ours are salaried, but, just talking about the telemedicine aspect, I've really tried to encourage our nurse triage pool to convert the phone encounters into televisits for the NPs. And it's not very much. I mean, it's like $8 or something, but you do 15-minute visits times 4, and then it times 2 hours times 5 times a week. It ends up adding up, as opposed to 30-minute phone calls for nothing. So we are trying our best. But yes, you're right. In terms of a productivity-based system and RVUs for efficiency versus access, I think there's a trade-off there, right?
For sure. But I did want to get back to one thing that you commented on. The patients are always asking. I don't think I've ever booked a single surgery without someone saying, well, what's the recovery time like? And the fact that we all have such very different answers for that is just so surprising. Like, we don't actually know what the recovery is. And so, the way that, I counsel my patients might be a little bit different than the way you counsel your patients. And is that affecting outcomes? I don't know. Is it subliminal messaging, or am I planting the seed that, your recovery is going to be really fast? And is someone who says, like, oh, you need to take 12 weeks off of work, is this a self-fulfilling prophecy? I think it's really interesting. And hopefully we'll have some answers on that.
I think the other thing that's really important is that it was one thing when someone had a big abdominal incision to tell them they couldn't do anything for like 6 to 12 weeks. But now we're doing really minimally invasive procedures. The patients are going home the same day. We're doing enhanced recovery after surgery, so they feel great. And I don't think it's even realistic to tell them to not do that anymore. It's like, what's the point of having all this minimally invasive surgery with enhanced recovery after surgery protocols if we're still going to say, don't do anything for 3 months?
It's true. I feel like this is one of those areas where there's going to be a bell curve, and 2 standard deviations are going to be 4 weeks or something. And then there's risk factors that are going to put you in the tail end of recovery. Like, maybe it's a history of chronic pain or anxiety or depression or substance abuse or whatever it may be. I'm just surmising. I don't know. But I'm sure your data will show some risk factors, or at least we'll know, because then this also impacts like U.S. workforce productivity, FMLA. It has a lot of implications for, childcare. It has its domino effects. Our patients are asking their parents and spouses and, friends to help take care of them. So there's a lot of things that go into this, really, that are complicated and complex. And that's why they schedule way out. I mean, we are operating on reproductive age women and, postmenopausal as well, but who are in the workforce mostly.
For sure.
Right?
Absolutely. And interestingly, when I was doing some research for some background information, I went to the Illinois Department of Public Health website. And do you know what they list as the recovery time for a hysterectomy?
Oh, is this 2 weeks?
Yes, 2 weeks.
That's crazy.
I mean, like, it's just really interesting. That's not, you don't see that around a lot. That might be very accurate, but I was really surprised to see that the Illinois Department of Health states that you should be recovered from your hysterectomy in 2 weeks.
That's so interesting that a state government would opine about like post-operative recovery on like a woman's surgery. Do you know what I mean? Like, do they say that for like cholecystectomy or
prostatectomy?
Reproductive things for women.
Like, why? That's so bizarre.
It's so true.
Did they read your paper? Were you cited in it?
I was just really floored that the insertion.
Oh my God. But yeah, it is true though. Like, we don't know about sling plus rectus repair, hysterectomy, whatever. Like, it's true. Like, I mean, I feel like the minors are fine. It depends on the kind of anesthesia. ARAS is I mean, the enhanced recovery, I always say that like changed my life. It was revolutionary, not having the patients stay in the hospital. But all of that, the early mobilization, the early feeding, it's just like the complication rate went down. We noticed that in our outcomes data at the Cleveland Clinic. When I first got here in 2020, people were still staying overnight, 1 or 2 nights. And then now it's just so much better. They're going home. I mean, of course, if they need to stay, fine, they can stay. But it's not the routine. And
Maggie doesn't let them stay.
Oh, you don't let them stay?
I think that's just a little bit of like, an overstatement. I always say that, there, 95% of patients will be able to go home the same day. There's a very rare circumstance where, unfortunately, I would have to keep you in the hospital if you have a couple of these things that happen that are just unavoidable. But we really try to do our best to make sure that doesn't happen.
I'm having residency flashbacks right now.
Yeah,
hearing that voice, the Maggie talking to patients voice.
But no, it's important. I think that yes, I think if we want to liken ourselves and in terms of the implementation science, think about ARIS. We all thought ARIS was great, but I think probably the anesthesiologist, this was definitely flying in the face of like everything that they had been practicing differently. Like they wanted to keep MPO status for, a long time, 24 hours, because they thought that there was going to be aspiration and all this stuff. And like, we really challenged their dogma. And it turned out, Amy, as you said, that everybody's doing better. And so it was definitely a mind shift for our anesthesia colleagues. And we just had to figure out a way to make that mind shift for our surgeons.
So what patients are you sending home? Everybody? Abdominal surgical colpexes, or are you only doing MIS anyway?
Yeah, we're only doing MIS, but, like robotic, hysterectomy, sacrocolpopexy, what have you, your blue plate specials, those will all go home the same day.
Yeah, and we've been doing that for a while, too, within our GYN subspecialty group. But it is a challenge. Some of the other docs are just not as comfortable doing it in spite of the data. That's the thing with data, converting it to practice. It's 17 years it takes sometimes for a paper to actually change clinical practice. Another reason why I like administration, you change the billing and it changes overnight. But yeah, from a hospital perspective too, we have the highest transfers in the country, I think. And so getting patients out who don't need to be in the hospital is a great way for other people to get care. It's not that, we want people home, but there's patients waiting in other hospitals who should be at a university hospital who can get in the door because we've got post-ops who don't need to be there. And that's a huge challenge, I think, for a lot of us. So it's not just good for the patients that we're treating, it's good for healthcare systems. It's good for patients who can't get the care they need because of unnecessary hospitalizations.
Yeah, COVID's actually one of the things that helped us. Like we were really, really struggling with the nurses sending the patients home. And when we, in our prior job, like they would literally basically tell the patients that, oh, you have bad doctors, they're making you go home today. I'm not kidding. And essentially we worked in a women's pavilion that closed. They didn't stay open all night. So the nurses just wanted the patients out so they could go home because like they basically had to say to the last patient was discharged. And this was like, we went round and round for probably a year. And then COVID hit and all of a sudden the hospital was highly motivated to have us operate because we can send all of our patients home the same day. And they realized they could keep the ORs running. What they didn't have was inpatient beds. And that was like a life-altering experience once the hospital was like, oh yeah, we want these urogynecologists operating as much as possible because they don't take inpatient beds. And all of a sudden, everybody got on board that it was like, oh, okay, like it's okay to send the patients home the same day. And even some of our team who were skeptical realized, guess what? Like we're operating, nobody's having bad outcomes. And I think that hospitals can really help by making some policy changes.
Yeah. And it's also one of those things like when you start to think about implementation science, just thinking about all of those barriers and the different things, I think we didn't realize for a while that, our patients seem to want to go home when we talk to them about it at their surgical discussion visit. But then it turns out that, the nurses in the pre-op and PACU were saying like, well, when I had my hysterectomy, I stayed in the hospital for 7 days. And, so it's just like those things that you don't think about, like, oh, we need to provide a lot more education. There's reasons why that wouldn't be good. And this is more contemporary and things like that. So just the things that you might overlook when trying to implement something, we've learned a lot of lessons.
I think you guys are really guiding light in that regard in terms of protocols and enlisting the nurses. Because I feel like you guys have put together a lot of protocols and pushed through a lot of things. And you're right. Nurses, anesthesia, we're all part of a team. And then having, like, what have been some guiding principles or best practices that have helped you adopt those practices besides, I guess you could do, we've tried doing these, not lunch and learns, but like these little sessions for the nurses, but you don't catch everybody. What else have you tried to like educate the team?
Well, I think that our immediate nursing team and mid-level provider team, we spend a lot of time in dialogue, and we really try to make them see that like the faculty, the surgeons have to all do it the same way. And so we get behind closed doors, and it takes a lot of talking and a lot of negotiations and a lot of reading the literature to try to figure out like something that we can all agree upon, that's evidence-based. And, there's places where evidence doesn't guide us. And that makes it a little bit easier for the staff and the fellows and the residents that they're not thinking, oh, Mueller wants it this way, Kenton wants it that way. And then I think that some of the ways that we've actually engaged the nurses and the APPs is we initially had nurse practitioners doing a lot of the pre-op counseling, and we teach everyone self-cath and going over the patient instructions and the ARISH protocols. And our nurses were like, we would like to do that. We think that we can spend that time educating patients. And so they just became interested that they wanted to be part of that healthcare team. And I think that we also spend a lot of time on terminology and semantics that, the National Academy of Medicine defines what team-based healthcare is. And so we make sure everyone understands that like we are functioning as a team, and we're providing team-based care, which actually provides value to our patients. And it also like provides value to every member of the team, because nurses aren't just doing trivial things. They're actually working with patients, they're educating patients, they're actually using their professional licenses to make decisions. And we take their input into things too. Like they'll come back and they'll say, well, you guys have started this protocol, but like there's a problem. Like all the patients are asking about this. Can we add this to it? And I think it's really keeping those lines of communication and really stressing the team-based care model.
And also, I completely agree. I think it's all teams. And I think sometimes it's important to really dig into who our stakeholders are in these situations. I think about like PACU. We want them to go home the same day. Our PACU nurses don't work overnight. So if I've got an afternoon case that's going home the same day, well, it's easier for them to get the patient to the floor, right? So they can close down the PACU. And so that's when...
We learned that the hard way.
Yeah. No. I think that's something we all do. But again, working with all the people involved and helping them understand why we're doing what we're doing, and the nursing leadership and PACU, and say, okay, so we're going to have some later cases. Getting them to the floor is not solving the problem. It's it's handing the problem off to somebody else.
Yeah.
So now the floor nurses have to admit a patient to the floor, do everything there, and then discharge them 3 hours later. Well, that's not necessarily the best use of hospital time either. And so I think...
And it's something for our patients.
Obviously, yeah, correct. It's not good for patients at all, but also if everybody has incentives going in different directions. And so everybody, let's all get together. If it were you, what would you want us to do? And like you said, you're explaining, communicating the why of all this so we can actually solve this problem. But there's always people you forget, and then you just apologize and say, sorry, here's what we're trying to do. Can you help us do it? But it is the thing I've said about minimally invasive GYN surgery for years, though, is, we all know about the relative value of what we do from CMS and the lower reimbursement, the one thing we do is minimally invasive surgeons, and you guys sending patients home early, being high volume surgeons and having high quality care is value. Our patients aren't coming back. They're not staying in a hospital. We're getting 3 cases, 4 cases done instead of 2. So a dollar saved is a dollar earned. That hospital bed day that I'm not using is worth money to this hospital. So you can say, oh, I'm not making as many you're not making as many RVUs. Yeah, but my patients are going home. So bring in that golden egg-laying goose from out of town that's going to, be a brand new patient and be a huge hospital bill for you guys to collect. Obviously, we're doing this for patients, but from a hospital administrator's perspective, yeah, listen, that hospital bed is now available for somebody else to use. And so I think as hospitals are now just full all the time most of the days, we bring a lot of value by just keeping the ORs going and then getting patients where they belong, which is safely at home.
Yeah, I couldn't agree with you more. I think the value of outpatient, it just is one of those things that aligns, it's the best for the patient. It's best for the hospital. It's great for everybody all around, cost savings. I think in terms of team-based work, we have a very strong nursing culture here. We work with the NPs, nurses. Couldn't agree with you more. I would also say that, I know for myself, and I emphasize this to my team, we as surgeons need to look at our schedule and make sure that it makes sense. I think for me personally, I like my day to start with the hardest case and go downhill. I cannot tell you, I used to go in residency and as a fellow, I'm like, oh my God, starting a robotic sacral colpopexy at 2 p.m. after doing 2 vag specials, that's not the day I want to have. I always start my laparoscopic sacral colpopexy first, and then I do the vag special or the, sling and rectus repair or whatever. And I think just communicating with your scheduler, because I do also just show up and operate, whatever they have put on my schedule. But if she knows what my preferences are, she can schedule appropriately. It works out best for me, the patients, the PACU, having the appropriate mix. But you just have to let your team know. Because again, I am not a scheduler, but after knowing that Dr. Hoffman, Dr. Mueller, Dr. Kenton all want it this way, then it's easier because they just know you because you're very predictable. The other thing I always say to people is you don't want to be an always never surgeon. I always do it this way. I never do it this way. And you're like, I have whiplash. It's 2 hours later. Different. Being predictable about your preferences so that and consistent, like you're saying about aligning your team, Kim.
Yeah.
I think it's super important because if you are so predictable that people know what you're going to say and how you're going to say it, and the residents know and the fellows know and your nurses know and your schedulers know, I think that's also really helpful, right? For everything.
We have a preoperative grid. I actually don't like to do the same thing over and over again. And it's the exact same way for every surgeon, but they want me to put in a surgical request. And they had so many fields that I needed to fill. What type of anesthesia? What do you need? I'm I need the same thing. How long is the case going to be? So, and I literally I'm not obedient. So everyone would fill out the whole grid and I just would not. I would say she's having a laparoscopic sacral colpopexy. And then it would be sent to somebody else to actually... Even when she was a full-on associate professor,
we're talking about 2 years ago.
And I'm I just
Maggie's pointing at herself for our listeners at home right now or in the car.
Oh my God, that's hilarious.
And so literally we do it the same way. So now I could put down she's having a single port robotic his colpopexy, and they could go onto the grid and they could say that should take this amount of time. We need this anesthesia. They get this preoperative antibiotics. And nobody needs to do that every time. The surgical schedulers have this grid, and it looks the same for all of us. To your point, Amy, about predictability, which makes it better for them. And then they're also not calling me 100 times saying, what do you want here? What do you want there? The same thing that I always want. So we just wrote it out for them.
Can I ask about, you mentioned single port. I was going to ask about the vaginal cup, but I guess I'll include single port as well. When we talk about like 5mm, 8mm incisions, like I feel pretty good about a very, very low rate of herniation complication if I'm doing laparoscopic cases. Those incisions in the last dozen years have not caused me a whole lot of trouble. I've had very few cuff dehiscences. Thankfully, it's rare, but that's the ones I think most of us worry about when it comes to hysterectomy. And you mentioned single port. That's what, a 2.5, 3 centimeter umbilical incision as well?
We do about a 1.5.
Oh, okay. That's pretty small. I think when I do more silation now, I do a lot more mini lap fan and steels because one of my hernia surgeons is, and a lot of the data we've reviewed, the hernia rates on larger umbilical incisions is like 30-something%. And so a mini lap, the old Arthur Haney mini lap fan and steel, you can get a 5-pound uterus out of that thing pretty easy, and the incisions hidden, and they do great.
I have to interrupt you just because, see, I'm not lying. All these things are true.
These are the University of Chicago stories that, my whole team, Christina Lewicki got the train there. Sarah Collins worked there for a long time. So they all three have these U of C stories that I'm just now.
People do not believe them, by the way. Maggie and I were talking about this at SGS a few years ago.
It's true.
And people thought we were kidding. They're like, no.
Yeah. Like what? I want to hear the story.
This is not. This is
Catch me up.
This is an SGS off air. Most of our stories, Maggie.
Yes.
I would say this
sure.
is not something we want to like.
So.
Some of them are cute and funny. Some of them are definitely not ready for primetime radio.
Well, when Maggie would tell stories, I would be like, how is that possible? That's like when I trained 15 years before you. It can't still be that way. She's like, and then when we started working with Christina, she'd be like, Christina, tell her.
Yeah. And it was all legit.
Yeah.
We can do a mad fan and steel, 4 centimeter. You can
That's
do
when you're
anything.
so well trained. I mean, honestly, I will say that training made you guys good.
No, I mean, we can laugh all day long. We had to do a lot, and we were not supported by everybody along the way, and we had to figure things out. And I do think that helped us in a lot of ways. But those things were so unbelievably small. As mini lap fan steels, they were 2.5, 3 centimeters. You do abdominals or collage, and you're like, there's no way. Come on now. This is not like a salpingectomy. And you do it. But now, I use that for my, tissue extraction. And we'll take
Why don't you just do it through the vagina?
So if we're doing, it depends on their parity. If they've had a couple C-sections, and there's just, the vaginal cuff is not much bigger, but it's also a lot further away. And if you've got a big, giant, bulky, round fibroid, it's just hard to get to. So I do vaginal morcellation when I can. The applied bag is great for that. But for the really, really big ones, it's
easier abdominally.
Oh, yeah. And I don't think I've had a mini lap fan still come back for anything. They do great. Now, maybe, and the hernia rates are low. I think the pain's a little bit higher compared to umbilical, but let's talk about the vaginal cuff, though. So pelvic rest is what, we call it. The patients have no idea what it means. Sex or anything in the vagina, for me, it's still 8 weeks. Is there any data on that? Or are we all still just kind of because we've had those patients I was having sex right afterwards and I'm fine. We've had patients that have had dehiscences with nothing. What's the data on that?
I mean, vaginal cuff dehiscence data is so hard to interpret. I think no one has a really great answer. I think we use 6 weeks. It's not really terribly data informed, but, we are closing the cuff with Maxon or PDS. So the cuff should be pretty well approximated by that 6-week mark.
Are you doing that? So that's PDS or Maxon with vaginal hysterectomy? Are you doing that for robotic as well, or are you using barbed suture?
No barbed. So we would use that for our, if we talk about single port hysterectomy, colpopexy. We are a group that performs total hysterectomies at the time of our sacrocolpopexy. So everybody has a cuff. And we haven't seen a large, we haven't seen cuff dehiscence. It's just so hard to study, and there's so many other things that go into it. I don't think it's just an activity restriction type issue.
I would guess the sacrocolpopexy would be protective against cuff dehiscence. You're kind of putting a mesh, wrapping it around, right?
Try to stay away from the cuff with the mesh.
Or do you go around it?
Well, there's usually 2 centimeters on either side where there's no mesh. So the cuff, and then 2 centimeters anteriorly, there's no mesh, and 2 centimeters posteriorly, there's no mesh. And again, that's just to prevent a mesh exposure at the cuff. But with respect to the I think you're right. So this certainly single port robot, it is newer, but single site has been around for so long. And there were increased hernias through those umbilical incisions. And that actually allowed us to kind of take that data and adapt the way that we practice. So we closed those single port incisions with Proline. And while it's a newer surgical platform, we have some data that should be published pretty soon with some pretty good outcomes. And thankfully, we're not seeing a high rate of postoperative hernias.
Are you guys all doing single port?
Most of our group does single port.
Really? Interesting. How long have you guys been doing that?
We started back in 2021. So, and I think, I do think that it impacts recovery just because you're not going through multiple different muscles. You're going through the umbilicus where you're just separating the muscle in the midline. The patients do really well.
I will say for what you do, I think it would be less ideal. I mean, maybe for endo cases, but the instruments, I mean, the uteri we have are this big.
And that's what I was thinking. I'm not sure how I'd get around a 25-week uterus.
You could probably get around it because the whole thing would move around it. But the instruments are so small that you would be sealing each blood vessel for 10 minutes.
Oh, I see. It's actually a smaller.
Even ours, when we have like a 250-gram uterus, which is like big for us, small for you.
A cuterus is what our residents call them.
Yeah. I mean, like the instruments are just like the vessels, the instruments like the bipolar that's sealed is so tiny that like it's sometimes even our little postmenopausal uteri, you can't like grab the uterine and seal it once. You got to seal it like 4 times, which like in 4 little sections, which I mean, you would be there for like 6 hours. I think that would be the limitation. I think it would be great for like endo cases because you can really move the whole thing, to different places.
And with myomectomies, it's one of the surgeries I do where they're going to need a second surgery, like they're getting a C-section. So like this, vaginal cuff tissue extraction or doing an umbilical incision for extraction, like they're getting a C-section if they get pregnant. So just use the fan steel as one of your ports. Like it's an incision they're going to get again. So if it's about cosmesis or things like that, like I tend to use mini laps for myomectomies too, even just doing the whole way, because if they're going to have all those robotic incisions and then get the fan steel, it's like, well, then just say, at least offer it. And I have a lot of patients who will say, actually, can we just skip the robot incisions? So
how long are the single port TLH sacrocolpopexy taking?
2 hours.
Yeah, I think they're probably the same as the XI ones. This is one of the things that we're looking at too, to see if there's differences with respect to recovery and pain in single port versus multi-port robotic sacrocolpopexy. So hopefully we'll have some information to share soon. I know there's a lot of things that we're hoping to have soon, but yeah, I do think, I anecdotally, the recovery is fast for these patients.
I mean, obviously there's a small learning curve, but I think it's actually, we do a lot of straight stick and we did a lot of XI. And I would say the single port is somewhere in the middle. It's not as slick as the XI as far as wristed motions, but we did so much straight stick that we were able to get around that. But there are some nuanced differences in the way you get traction and counter traction. But I would say the learning curve of transitioning, from open to laparoscopy as an attending, from laparoscopy to robotics, were both infinitesimally harder than switching to SPA. I would say within 10 cases, we were on autopilot.
That's very cool. It's interesting.
That is interesting. That's very cool. Well, I think we are just at about an hour. So unless there's anything else you wanted to ask, burning questions, Mark?
Well, I just wanted to get for our listeners and for me, just like an overview of like, okay, what's the take home? So activity after gynecologic surgery, benign gynecologic surgery, we're saying go to
just do it.
Just do it. Like we're going to lift weights and
you're going to do what your body tells you or allows.
Okay, so no activity restrictions. And then pelvic rest, nothing in the vagina for, is it 6 weeks?
I'm leaving that up for you to solve as our expert, minimally invasive gynecologic surgeon.
So the answer is we don't know yet, but you guys are doing 6 weeks?
We're doing
That's
6 weeks, yeah.
Currently? Okay.
For slings, we've just did a randomized controlled trial with Wake Forest. We're randomizing people to allowing them to have intercourse after 2 weeks. Haven't seen the results yet.
All right. Well, we will. I think I'm probably just going to tell her to do it ever because Maggie and Kim said so.
Yeah.
And all that data. Yeah. Well, first of all, thank you guys for coming on the show. Thank you guys for all the hard work that you do. And it's so good to see when we get to have our friends on the show. It makes it more fun. And Amy, anything else you wanted to add?
No, thanks so much for coming on. Always fun to talk with you guys and hear about the cutting edge data that you're adopting and producing. And thanks for all the work that you do.
Well, likewise, this has been great. And it is really fun to chat with our friends and colleagues and learn from one another. So thank you for having us.
Yeah, we really appreciate the time and the fun dialogue.
You guys are the best. Thanks for coming on, and we hope to see you guys soon.
Awesome.
Bye.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
And Amy Park.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer,
Design and Digital Marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess and Yvonne Orgoginski.
Show notes and social media by Emma Landenwich
and Lindsay Beecham.
Administrative support provided by Kimberly.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own and do not reflect the views or positions of their employers or any entities they represent.